Oh, no. All right, Sue, should I get started or do you have any
Yeah,
announcements?
why don't you get started? I'll mute myself.
Okay. All right, good morning, everyone. Chris Tangen, thanks, Sue, for inviting me to talk about this. This is something that I see a lot in my role at Kent State University. So this is something that is really applicable. And I think the best way to do this talk is to kind of set the stage of how sports are important. I think everyone on the Zoom this morning knows that we all love sports, but we'll still set the stage and kind of talk about what happens here in the city and then at Kent State, and then we'll go into some recommendations about being a team physician, handling mental health. And then at the end, I'll have a whole bunch of slides with some stats and numbers, and we'll kind of go through those, obviously, for test material. But go ahead and get started here. I think sports are something that you're really passionate about, and everyone here is also, in medical school or through medical school. So the idea is, as you move from high school to college to medical school to a residency, fellowship, a job, you're still striving every single step of the way. And I think you could argue it gets kind of harder every single step. And then the same thing with sports, as you move from high school sports to college sports to pro sports, it's really stressful. And we're kind of at this weird junction at the NCAA. It's hard enough to get there, but then everyone, well, I shouldn't say everybody, but most of these athletes are striving for some sort of sports career afterwards. So I think there's a lot of pressure on athletes to perform, whether that's internal pressure from themselves, type A personalities, which we'll talk about later, or if it's pressure from their team and community. So we'll kind of go over some reasons why you might even want to be a D1 athlete in the first place. I got to participate on the Miami University wrestling team, and I would say even back then we got some perks. Nowadays, there's just millions of cool things. There's athletic buildings just for athletes. So I didn't have all that when I was a wrestler, but it's still kind of a cool thing. It's good graduation rate. You get to be involved with a lot of other great benefits, opportunities, experiences that you wouldn't naturally have. Just in my team physician role right now, I doubt that I would ever be on the field at Seattle, Norman, Oklahoma. Next year we're going to California. So just cool opportunities and experiences that these student athletes get to do. There's financial assistance, whether that's, this insurance, or whether it's for actually going to school and books and food. If you injure yourself, you'll get that covered from an NCAA standpoint. So lots of great benefits. The other thing is, with all this NIL stuff and donors getting kind of closer to the athletes, it even happens at Kent State. So there's a lot of personal and professional development that these athletes get. It's really tough to do that. Only 7% of people go from high school football to NCAA football, sort of at any level. And then it's about 1 or 2% that go on to pro. So football is pretty tough. And Ohio is a pretty good state as far as getting people, but you always think about these SEC countries where the athletes are coming from. Basketball, it's even less, just because there's fewer people on men's basketball teams, more teams, but fewer people. So 3% go from high school to college level, and about 1% go on to the pros. These are the states. Kind of the DC area is sort of that basketball mecca. And then I always kind of like to highlight wrestling as the hardest one to get to percentage wise. So, and then before you think I was good, I got destroyed when I was at the college level. So, but it was fun to be there. And Ohio and Pennsylvania are definitely some of the bigger wrestling states in the nation. But in the city of Cleveland, I mean, there's some pretty high level stuff that happens. When LeBron and Dwayne Wade were on the Cavs, they came to see one of my patients play at the high school level. He's now at Arizona State. But some really high level stuff. And even this year, some of our Cavs players came to watch our Richmond Heights guys, and Donovan Mitchell's even tweeting about Richmond Heights and Brush. So those are two of the high schools that I take care of. So kind of cool that these guys are involved in the community. But then I think this also leads to a lot of pressure, and not everything in the media is positive. So this is a slide. Last year, Kent State players immediately go try to fight the Akron student section. The Akron student section is pretty rambunctious, and our guys tried to fight them after we beat them last year. So not every story in the world is good. This is a story about how it's actually one of my patients that kind of did this. But there's a Brush versus Shaker Heights basketball game, and there was a huge fight. You could be industrious and find that on YouTube if you really wanted to. But lots of stressful things. Some are positive, some are negative, but even stress in the Cleveland area. So some of us are lucky enough to get recruited. Is that where all the drama and hard stuff ends? Absolutely not. So even at Kent State, we have prospects sign this form. And I think it's interesting, even at little old Kent State, number 2 is, did Kent State University provide you or anyone with you alcohol or drugs while on your visit? And then number 3 is, did Kent State take you or anyone with you to a gentleman's club or strip club while on your visit? So again, a lot of stuff happens, good or bad, even in the local sports area here. This obviously recent graph of covered all over as far as anxiety and stress going up in sort of the high school population, which obviously turns into the college age population. All right, so maybe you got recruited, maybe you're on a team. Is that where the hard part's over? No, absolutely not. There's a lot of studies that show that this took a look at a football team and some pre and postseason self-reported symptom scores, and they all got worse. So at NCAA college football is super stressful, whether you're playing, whether you're winning, whether you're losing, all of these metrics got worse at the end of the season. So lots of stress during the season, regardless of where you are and how recruited you were. I see a lot of concussions. So this is a study that took a look at just your concussion patients and how often they're going to have some sort of mental health associated challenge with their recovery from a concussion standpoint. So 91% of the patients were also seen by this multidisciplinary psychology team as well. So it's pretty similar in our concussion clinic here, especially in my adult patients that I see in the clinic. But then also we've got to keep this in mind. There's a huge mental health component in this post-concussion syndrome recovery. So 90% of patients in this pediatric study needed to go see the psych team as well. So super prevalent. You want to think about mental health all the time. Well, what about something more sinister like suicidal ideation? It's less, and we'll go over numbers later, in the athletic population, because you're part of a group and usually there's some accountability, even if there are some bad things about being in a sport. But there are some risk factors that we should kind of think about. If male athletes are loners, that's something that you're going to want to kind of be cognizant of and try to keep close contact with them. And then your female athletes that have been victims of sexual or any kind of abuse, you're going to want to keep a little closer eye on those college athletes. This was a study that kind of took a look at elite track and field athletes, but just something to kind of keep in mind. The story I'll tell here from a Kent State side of things is, it was a few years ago when that Joker movie came out, but one of our athletes told us that he was having thoughts of doing similar things to what that character was doing and causing harm. So we needed to get our mental health emergency action plan, which we'll talk about later, in action. And we had to actually do that with him 2 different times because of some of the thoughts that he was having. So something that we are actively doing, and that was just a few years ago. All right, so there's other things that we need to think about being team physicians. What about something that actually doesn't happen to the athlete themselves, but happens to somebody else on their team? So there's secondary trauma or vicarious trauma. And it's something that we want to keep in mind. If something stressful happens to a team or something happens to someone's teammate, you're going to want to kind of keep an eye on the other athletes as well. So the example that I think works here is during the pandemic, the director of basketball operations at Kent State passed away. We're not exactly sure why he did that or what happened to him, but it really hit the men's basketball team, not this year, but last year, really, really hard. So just a lot of things that we needed to kind of keep a close eye on during the season. They really worked with him, lighter stuff like getting tickets for their friends, but then also, really important stuff as well. So that was something stressful that happened just last year. Okay, so from a sports medicine conference side of things, a lot of these conferences have, within the last handful of years, brings on survivors from some of the traumatic things that you read about in the news. And this took a look at, hey, listen, is that really the best thing for the athlete to go in front of thousands of doctors and medical students and residents, or is that even something that these organizations should be doing and bringing in these survivors? And I think the thought is that if done correctly, I think there's some good things that can happen from it. But I think a lot of us sitting in the audience are like, well, we're not doing this bad stuff, so thanks for the information and sorry that happened, kind of thing. But this is a chart that looks at some of the things that maybe from an organizational side of things could be helpful for both when you're at a conference, both the survivor of a trauma, but then also the doctors in the audience. I think a year ago, not just the Michigan State situation, but UCLA doctor, $240 million from an OBGYN standpoint. So lots of things are still happening out there. It's not just the big things that you've sort of heard of before. All right, so the pandemic is sort of lightening up from a sports standpoint. So has this changed athletes' mental health? Clearly it has. So this just gives a couple examples of during that emergency lockdown period, in soccer players, anxiety and depression doubled in soccer athletes. So this article basically said at the end, that it's going to happen, that things like, a lockdown, people are really engaged in their sports are going to happen. So clinicians and team doctors should routinely check in on all the athletes. Now, that's sort of a hard thing to do when you have 500 student athletes or you have a high school and you're not familiar with everyone, but as best you can with your athletic trainers, try to keep the pulse of everyone's mental health. All right, so we talked about all these different types of stress. We want to see if screening is a good idea. So all these organizations think that preseason screening is a good idea. There's best practices to have, and this is for when you're going to become a college team doc, but there's a lot of best practices to have in mind when you're dealing with a school. Now, does every school have this? Well, these are just the recommendations as far as what a school should have, but preseason screening, an environment that supports mental health and mental well-being, and also like an emergency action plan and a medical team if something does happen. So preseason screening is always kind of hard from our standpoint. We listen to hearts and lungs, we check out ankles and knees, but then mental health. So if you're an athlete coming in, you're already filling out tons of paperwork, and it's sort of a little bit of a process. And not that it's not important to the athletes, but what we find a lot of times is that they'll just kind of circle like zeros for everything or circle no for everything. And it's sort of difficult to do from our side of things. So at Kent State, it's hard to give them a lot of pieces of paper. So that's one of the things that I tried to pare down in the past couple of years, but I'll explain in a second what we do at Kent. But these are all sort of recommended by different sports societies. A lot of times, disordered eating, depression, anxiety is really hard to screen for. It seems really common that people would be anxious, but it's definitely hard to screen for anxiety. Can't we just generally use a GAD-7 to look for anxiety? But there's a lot of other screening that's recommended by those different organizations. Kind of hard to figure out which ones to do. So at Kent, we actually use an MMPI, and in the consensus statement from AMSSM, they did kind of touch on this. They said it's best done sort of face-to-face, which is hard to do, but we just provide them, I think it's 383 questions or so in MMPI. And we took a look at this. Dr. Gunstead's the neuropsychologist there that works with Chris Bailey. So took a look at it. I guess one disclaimer in the study, 338 items. One of the disclaimers is that our football coach wasn't super interested. So as far as doing MMPIs for those years that we took a look at it. But I think it's a valid tool, and I think it's been really helpful. We found, I think it was over 25% depression and a pretty close, maybe in the 15 to 20% anxiety. A lot of our depressed athletes admitted to not an active suicidal wish, but definitely passive thoughts of dying. So something that when we took a look at this, it was really kind of scary. So you're screening, whether you screen or not, depending on the resources that you have, we're lucky to be able to use an MMPI. and get that interpreted, but we also need to have a plan. So we have an emergency action plan, which I kind of illustrated that we needed to use a few years ago. Uh, at the Kent level, one of the athletic trainers is kind of in charge of that, and they meet every Monday. It's not something that I physically meet at, but definitely keep in touch with them. There's also an environment, and a lot of times the student governments, whether they're called SACs or SAGs or committees or governments, are one really good way for each team to have representation. So maybe 2 players from the football team, 2 gymnasts, 2 soccer players, so on and so forth, will sit on this. And this is, I've been in on a couple of these. These are generally done on Zoom now, but it basically lets everybody know what's out there for the athletes, if they need any assistance or any help. And then the representatives, generally captains, can bring that back to the team. So I've even seen where the team captains will stand up in practice and just read off what they learned at these SAC and SAGs. So it's kind of a cool way to disseminate information to the team. There's a medical management plan, largely probably done through you guys, through team physicians. So I think it's really difficult to kind of keep a close eye on this. A lot of times you'll go to a training room setting, depending on the school, depending on the level, and you'll either just, grab your phone and call something in or refill, or write on a paper prescription just because you're sort of mobile. But what I try to do as far as Kent State mental health is, even if I transcribe something at the training room, I'll put it into our EMR just to kind of keep that timestamp on things. And with prescriptions, sometimes this SSRI doesn't work and this one does, or this one has side effects. It's sort of hard for me to remember those things. So what I'll do is I'll connect with the athletes just on the phone or something like that in front of my work computer to keep that all in mind. I think sometimes you'll go into the training room and you'll just write like an inhaler, you'll write an antibiotic or something like that, just off the cuff. But with mental health medications, I'd sort of encourage you to use the EMR and not just do that sort of from the training room setting. There's a lot of school recommendations, and it kind of depends on the interdisciplinary team that you have at the school. I think at Kent State, we're pretty fortunate to have a good number of people. Not to, this is being recorded, so I don't want to say, but we're sort of building 1 or 2 components of our mental health team right now, so they're not fully up and running. But definitely, fellas, if you have any questions on that, we can touch base off this Zoom. So what should the team look like? It should look like this, but this is super hard to get. There's a lot of money involved. I've talked with our University Hospitals psychiatry team, and they're awesome. I love them, but they were interested in getting financially compensated for these services, and Kent State didn't seem to have it in the budget. And then Kent State wanted to go internal with their team, and there's a couple holes with that issue as well. So difficult to get everyone on board. So this is a survey that took a look at D1 head athletic trainers, and as we can see here by the percentages, 3%, 1%, 13% had these at their schools. So it's really rare to have everyone there. The team at Kent State, I know this looks like a lot of mental health team members, but largely it's the athletic trainers. So I always kind of put them at the forefront because they're with the athletes all the time. Maybe I'll jump on my soapbox for a second. I think there's a lot of things that the athletic trainers do well. Sometimes I worry a little bit if they're sort of too friendly with the athletes, in the sense of they're just going to worry about, the athletes' girlfriends, boyfriends, a little bit more than taking care of their injuries and so on and so forth. So every now and then there'll be an athletic trainer that I work with at Kent that kind of knows all these life details. And I try not to absorb all of that and try to sort of focus on the injuries. And I think that makes it difficult when it comes to mental health stuff, because some of the athletic trainers will grab me and they're like, hey, this athlete really needs some help. And then when I connect with the athlete, things are maybe better than they seem to the athletic trainer. So just kind of keep an open mind when you get information from a mental health standpoint from the athletic trainer. It kind of depends on how much you trust the athletic trainer and how familiar, obviously, they are with the student athletes. Just some general resources here at Kent. And this is my psych note template that I do sort of from the training room side of things. I always try to get a sense of let's see, coming in clear. Yeah, the onset of what's going on if they've had a prior psych history, I think is important. A lot of athletes won't really admit to that, but then if you talk to them a little bit more, they'll tell you that they had some problems in high school, and this is sort of what happened to them when they were in high school. A lot of times when it comes to sports performance, that's a good way to introduce mental health screening to these athletes. And the problem, well, I shouldn't say problem, but one of the things is that they were so good in high school. Now that they get to the college level, they're not quite as good in comparison to their peers. So some of these mental health challenges are coming more to a head. I think coping is really important, just trying to see what they do when they're stressed out. Athletes nowadays do things much differently than when I was an athlete a million years ago. So I just ask them what they do to relax. A lot of times it's listening to music. What their support system is, whether they're from Ohio or whether they're from California, makes a huge difference, of course. Any current medications that they're on, birth control pills, so on and so forth. Sleep is super important. So we definitely try to tune in on sleep. I just connected with one of our football players recently who was supposedly going to have a really big impact this year, and he was having some terrible sleep issues. So something that we do pretty often. And then sports considerations, obviously what team they're on, but where they are in the are they a starter? Are they sort of a bench warmer? And that's really important as well. So does all of this work? And now we're going to kind of talk about some of the stats. I think as far as these strengths of recommendations, level A is the highest and the best. There's these bolded ones is where we have a strength of recommendation at the A level, so the strongest level. And I think a lot of this with our consensus statement, there's a lot of good information that we'll talk about here, but it's really challenging to kind of put that into use and see what happens. So this article talks about, the competitive nature, like I outlined in the first few slides. So a lot of different personalities that you're going to deal with. We at Kent State cheat with the MMPI, but there's a lot that you see. I mean, perfectionism can lead to a lot of disappointment and depression. Pessimism, when you get down on yourself, obviously that's not great. And then an aggressive behavior could lead to bad habits, whether it's abusing drugs, whether it's violence, bad habits, so on and so forth. So I think this culture and how you deal with mental health is important, trying to get to know your athletes. And then again, the article kind of focused on having this athletic care team and mental health care providers at your college that can assist with sort of detecting this, whether it's preseason screening, whether it's getting to know the athletes with the athletic trainer, if they're, appropriate, and then kind of figuring out how to handle these psychological issues with the athlete population is always hard as well. So as far as numbers are concerned, the article kind of, and I'm going in the order of the article, but when it comes to issues with sexuality, the 4% of athletes report, and this was years ago, compared to 6.2% of athletes with kind of trying to either figure out their sexuality issues. And then as far as sexually related bullying, 32% of males, 14% of females. So I think this is kind of interesting behavior. And a lot of times it's not exactly what you would think of. So I'll go into a couple examples in just a second, but a lot of athletes don't report because they're going to perceive that their starting roles or their playing time is going to be affected. So I think if they do seek treatment for these things, being, comforting, being, upfront, being transparent is always important. So just an example with something like this, and I think at the end we'll give an example, but at Kent State, if someone does come to us with this, there's 2 or 3 different things that they have to go through. Some of the athletic trainers are sort of involved at the Title IX and other sort of athletic director levels. So there's more resources than just me. But if there is a problem with this, so we had, I don't want to say the team, but there was a male team and a female team, and the male person raped the female athlete, and it was a huge issue that we had to figure out. Is anyone going to sue anybody? Does this person feel safe? Because they actually lived in the same apartment complex. So there's a lot of factors. The female athlete decided to transfer out from Kent State. It was too difficult, and connecting with her was really tricky because she took it really hard and actually didn't tell anybody else besides our core member inside of Kent State. And then the male athlete is still part of one of the teams that we take care of right now. So just kind of a tricky situation. As far as hazing and bullying, I was sort of surprised with this. 80% of NCAA athletes say that there's been hazing, but I think this is sort of difficult because there's a belief that it's team building. It's running at 3 a.m. that could be hazing or that could be team building. So I think it's sort of tricky. Everyone on this call has probably been hazed in some way, shape, or form. But I think it's when, as the definition says here, it's sort of not all the time, humiliating, and it could be dangerous. I think that's sort of what the NCAA was trying to take a look at hazing, and it's an unsure effect of how to handle this. Obviously, the article talks about preventing every bad possible thing, but again, the effect on the athlete is sort of hard to figure out. Bullying is a little bit more difficult to define. It does sort of overlap with hazing, but the actual definition is abuse and mistreatment of someone vulnerable by someone stronger or more powerful. So you think about a coaching example. This doesn't happen very often at the NCAA level. Per the stats, it's usually a little bit more common at the elite athlete level. And then it's sort of an unsure effect exactly. And again, I'm not saying that you should have hazing and bullying, just more so it's hard to determine what these do to the student athletes. Sexual misconduct, 2 to 48% of athletes have reported this, slightly higher, again, like I said, in elite athletes. And then as everyone knows, we take the safe sport classes for some of our national level sports, and especially if we're going to work with youth athletes as team physicians. Transitioning away from your sport, whether it's the end of your career, you run out of eligibility, you got injured, it's a sports ending injury, you're not having fun, or just the risks and rewards of playing a sport aren't there anymore for you. So lots of different reasons why people transition away from their sport. A lot of schools have workshops for what to do when you're done with your sport. A lot of athletes go into coaching in one shape or form. And then there's also something that we do at Kent is sort of offering other either psychology services or life management skills. So it's kind of something that our compliance and our sort of life coaches at Kent State do, which is, I think, really cool. I think we do a good job with that. I wanted to talk about medical redshirting. It's a confusing issue. I thought it was going to be pretty easy. I thought it was going to be simple, like someone breaks their leg and they can't participate this year, so you write up a medical redshirt. But I think in my experience, it's a little more nuanced than that. So when you guys get out there, if you're involved at the college level, it's pretty difficult because a lot of the athletes are going to use any medical condition they want for a medical redshirt. So one of the things that we adapted from one of our other MAC schools, Buffalo, at Kent, we didn't have a protocol as far as how the athlete would need to get a medical redshirt. So now, because we're having this mental health talk, a lot of the issues were mental health related. And then not necessarily did I know about every single athlete's mental health. So a lot of athletes were saying, well, I was depressed, and when the coach kicked me off the team, it was because of a mental health problem. And it's really hard for our legal and compliance team to sort of sort that out. So what they do is they review all of our medical records. Again, another reason why you want to maybe put that in the EMR and then make a determination. But ultimately, we have to make that determination from our side of things. So it's a nuanced conversation. I thought it was going to be really easy. Break your leg, you need a year off, but it's much more complicated than that when you get into it. I probably had, for each one that we do, maybe 10 hours of work behind the scenes. It's challenging. What about bad habits, drinking and drugs? 80% of NCAA athletes drank in the past year. A lot of the teams at Kent, the captains will have all of the team members sign something saying no drinking during the season, no partying during the season. And that's one of the big reasons why a lot of the athletes get kicked off of teams. Excessive drinking has been decreasing, so that's great news. And then marijuana use, I thought it was going to be really high in athletes, but it's a little bit lower than the average college general population. So 22% of athletes, 33% of general population. I think you can imagine what teams in general are higher at this than other teams. And then as far as opiates, 6% of use without a prescription, which is pretty scary. And then in one study of retired professional football players, 71% reported misuse of opiates. So I would say that might be something that happens in my world more from an orthopedic surgery side of things. I can't remember the last time if I've ever written a narcotic at Kent State. Depression, super common. So what we found at Kent State was pretty similar to the reported data, about 23%. Females greater than males, and the freshmen are the ones that we're going to have to keep a closer eye on because that rate is highest in freshmen. Obviously, there's a transition from wherever they were living to the college campus. As far as medications are concerned, this is also a little tricky. I think you want to get the athletes buy-in, which is something that you guys have done your entire medical life, but also from a college sports level, performance is a huge issue. So when you go over the risks and benefits of all these medications, there's side effects to every single one of them. So it's really difficult. But I would say at the college level, kind of tried and true SSRIs are the ones that have been most successful for me when I'm writing medications for college athletes. My go-tos are usually Lexapro or even Prozac, the OG SSRI. And then something that is written in the article is to consider Buspar if you sort of identify a little bit more of the anxiety component that's not being treated with an SSRI, you're going to want to consider Buspar. But I think that's difficult because I would say most of the student athletes don't see any benefit whatsoever from Buspar, even at different dosages and dosing schedules. A lot of times it's dosed twice a day, which is difficult for the athletes to do, kind of depending on their busy schedules. So I would say I haven't had a great success with Buspar. A handful of the athletes are on it, but SSRIs in general is what's been a little better. Cognitive behavioral therapy is super important. So it's the combination of medication and working with somebody. At Kent State, what we have is Kent State has a mental health team and they provide someone to athletics, but that's sort of one of the areas that we're trying to improve a little bit at the moment. And suicide is lower. So when we think about the side effects of depression being suicide, I know we touched on it earlier, but it's lower than the student body, again, because the athletes are connected. So it's under 1 per 100,000 per year. From an anxiety component, again, as we talked about, there are anxiety screens. We use a GAD-7. That's only been validated in the general population, not really specifically for athletes, but it's what we use pretty quick and easy. And it's sort of difficult to determine the percentages in NCAA. So in the general public, it's about 3% for generalized anxiety disorder. And then OCD does seem to be a little higher in athletes, and that perfectionism, mental health personality that we talked about earlier that sometimes we see. But if we find this SSRIs, we talked about Buspar on the other slide, and then cognitive behavioral therapy. But again, Buspar hasn't been super helpful in my experience. Overtraining syndrome, it's hard to determine the percentage, but 10 to 64%. I think a lot of our distance runners experience some sort of, whether it's REDS or whether it's overtraining. I think a lot of our distance athletes at Kent, we want to try to stay cognizant of this. So what we do with these athletes is we try to get them in really quickly with our nutritionist. Sleep, super important. Poor sleep has 2.5 times the rate of depression, anxiety, and somatoform disorder in athletes. There's a sleep screening questionnaire that is clinically validated for athletes. Melatonin, as you guys are familiar with, is pretty safe in the short term. And sorry, typo here, but trazodone, it's not proven in athletes. Antihistamines, that's what a lot of athletes grab. They just grab a Benadryl. There's some weak evidence for antihistamines, and there are obviously side effects to antihistamines. So with sleep, I would say with the athletes, we try to screen the athletes that complain of poor sleep for mental health. So that's what we did with the football player that I talked about just recently. I think that was last week. And then they've almost always tried melatonin. So sometimes you're going to want to have a consideration for other medications. But as far as my experience, I don't write for the controlled sleep medications. ADHD is super difficult. I'll spend a minute here just because this is something that if you run into, you're going to have to take a couple steps. So one of the things that we do is we make sure that a specialist has diagnosed them with ADHD if they come in and they're, super smart pediatrician or maybe even sports doc started writing for ADHD medications, but did not put them through any kind of ADHD testing. We have them redo that at Kent State. So one of the biggest ways that we do that is Big Ten and SEC players that transfer in, almost 100% of them are taking stimulants. So what we'll do is a lot of the huge schools, the bigger schools have everybody take ADHD testing. But for us, if they come in from one of those schools that doesn't do that mandatory testing, then we have them redo that at Kent State before we'd consider doing medications. There is an NCAA form that you have to fill out when it comes to stimulants. We use an adaptation from the AMSSM paperwork. So a lot of times we document this, or I shouldn't say a lot of times, but all the time we document this on the UHEMR if we have this. So a lot of times someone will transfer in, we'll do the PPE, they'll say, hey, I need my ADHD medications. Hopefully their previous provider gave them a month or two in advance. We try to get them connected through Kent Mental Health right away. And then I can start helping them out once we get all that documentation. So lots of steps here if you want to do that at the NCAA level. So summaries and conclusion, I'm not going to read all of these. It's in the consensus statement, but I just wanted to point out that as far as the strongest recommendations, they're only in those bolded ones earlier. Personality issues, we talked about that, how we handle this at the college level. We cheat with the MMPI, but we're able to kind of take a closer look at personalities. Sexuality and gender issues, we talked about them. Some good evidence that having a supportive environment is helpful, and I think we definitely have this at Kent State. As far as hazing, sort of hard to figure out what to do with it because it does overlap with just trying to be a good team and build the team, and this is what we did when we were freshmen. Bullying, of course, is negative, but it's hard to really define and kind of hard to take a close look at from an NCAA level. Sexual misconduct, we talked about a couple sort of terrible examples of this. Transitioning from sport, I think we do a great job with this as far as getting our athletes sort of on to the next step of their life. Whether you retire from an injury or you have a problem that it's taking a long time for you to get back, I think mental health is definitely related here, and this is something that we'll take a close look at these athletes when they are dealing with these chronic injuries. As far as self-medication in response to injuries and illness, luckily there's not too much of this, but of course I don't know every single thing. We do drug testing, that's another huge topic, but we do drug testing at Kent. Our marijuana cutoff is below the national average. So classic examples, if you're just at a party, you might test positive at Kent State, even if you weren't using it yourself. So we do drug screening. And then as far as eating disordered and disordered eating, we're lucky that we get to use our nutritionist at Kent State, and she has a team that help her. But then also we're going to keep a close eye on this when it comes to performance, overtraining syndrome, REDS, and other similar types of medical issues that you guys deal with. Depression and suicide, we talked a lot about. Anxiety and stress, hard to screen, but at Kent we use a GAD-7. Overtraining we talked about, and sleep, super important. So just one of the better recommendations is not to use those controlled substances. ADHD, if you're doing that at the college level, lots of steps that you need to take. And then these are sort of, just so I don't have to break HIPAA, these are ripped from the headlines. So this is one of our defensive backs that transferred from Maryland, and he used depression as the reason why he came in, didn't need to sit out. And then he used depression to transfer to UCLA. So he kind of did the same thing. This is one of our women's basketball players that admits to some sexuality and gender issues. It was really cool to connect with her about these things, but also kind of difficult to manage. And we needed that multidisciplinary team to help her out, but really cool to work with her. And then this is one of our basketball players that we brought in with autism. So it was a great story, and it was covered at all the national levels. PJ Tucker, one of the NBA players, came in. So this great story, but then his mom says that he was mistreated at Kent State. So obviously hard for us as a medical staff. The article, and actually Kalen and his mom are patients of mine. So I kind of know the real story here, but suffice to say that even some stories that start off good have this huge mental health component. And you don't, from our role, don't want to be in the newspaper about it. That would be a terrible thing. MAC conference level, so taking 3 steps backwards, we put on a symposium every year, and a lot of our UH people are involved with this as far as kind of educating. So all the schools kind of converge on Cleveland once a year. I think it went away for a couple of years during the pandemic, but it has restarted. So something cool that actually happens in Cleveland for the MAC conference because it's based in Cleveland. All right, guys, I know that was a million slides, but hopefully you got something out of it. I think I shared the slides with Sue so she can send them out as well. And the consensus statement is good. I think when the middle part of my talk was as far as the practical aspect of doing mental health at the college level, it's not a perfect situation, especially, even what we do at Kent State is not perfect. There's lots of room for improvement. But I think if you take kind of from the consensus statement from your previous experience and getting to know the athletic trainers and the athletes, as long as you have a good rapport on all those levels, I think you can do a really good job. So I'll take any questions. Thanks, guys.
Tangen, this is McFarland. Do you mind just mentioning a little bit more about the blurb that you throw into the EMR? I think it's a good tip. And you're doing that with like all SSRIs, or are you doing that with like ADHD meds too and all of that stuff?
Yeah, well, for sure ADHD meds, because those are sort of the controlled substances. But what we'll do is we'll get all the information, scan it into the EMR, and then from that I'll Zoom or FaceTime. If we do the UH EMR thing, the athletes can't figure that out. Like no patient can figure that out. So we'll just do a Zoom, and then we'll put a visit on the chart for that and make sure that they're following up. So one of our football players, for example, he'll just text me. And recently there's been a huge ADHD med shortage, as you guys may have encountered in your other patients, but it's a huge problem. So if I didn't have the EMR, when I prescribe like 6 pills to the Meyer Pharmacy in Stowe, and then 24 pills to the CVS in Talmadge, like it would be impossible for me to track that without the EMR. So yeah, I have a blurb that we put in to that for ADHD. And when it comes to depression and anxiety, that first template that I showed, I put that into every single one and make sure I get all the information there. And it's actually helpful for me moving forward. I have a dot phrase that I use that talks about the different types of medications and side effects and the Kent State considerations. And I put that in the note at the end. So then if I do touch base with them on the telephone, at least it's in our medical record that I talked about switching medications or potentially adding something. So I don't need to create like an entirely new note for that. I just update those bullet points. And I think that's probably a good thing. Obviously, when we think about mental health, there's a million other questions that we could ask, but those are kind of my hard-hitting questions that most athletes will answer. I think sometimes some of the athletes that have children themselves that come from broken homes that don't want to talk about their family situation, I think if I pressed too much into those issues, I might lose the connection with the athlete. So I try to stay to those main things.
Hey, Chris, what are you doing for ADHD testing for these athletes? Is it just questionnaires?
Yeah, so there's questionnaires. There's probably I can maybe send you what we're doing. I can't remember all the tests off the top of my head, but there's a battery of about 6 or 12 tests. So the report comes back to me. Sometimes it's like 20, 30 pages long. So Kent State Mental Health Services help out with this. And a lot of times they can't connect with them, or when they connect, then they don't write for the medication that works best for the athlete. And it's just impossible to get back in touch with them. So once I get the diagnosis that says that they have ADHD, then I can kind of go back and forth with medications with the athlete. Spoiler alert, they all want stimulants, but sometimes the health department will use something different, whether it's clonidine or whether it's other medications. I can try to find that for you, Suze.
Thanks. I appreciate you giving the talk today.
You got it. It was fun. Thanks, everybody.
Thanks, Chris.
Thanks, Dr. Tangen.
Thank you.
See you guys.
Thank you. That was great.
Yep.